So I'm going to run through a little bit of basic DALK and DALK steps, especially the big bubble DALK, and then we'll hand it over to our next masters who will take other steps. Move nahi ho raha. Move nahi ho raha bhaiya. So of course, we don't really need to get into why DALK. We all know it's because there's so much advantages we're leaving behind the endothelium there. There's a lot of wound strength that we have, less intraoperative complications, patient's healing time, and of course, we can taper the steroids faster. And there are a wide variety of indications that we could use this surgery for. Ectasias are one of the most common that we rely on this surgery for, of course, but they can also be for various types of dystrophies, corneal opacities, and certain infections, as we'll be seeing later through our talk. Bhaiya, move nahi ho raha hai. So the points to keep in mind when we are planning our DALK is what is the underlying pathology that we are trying to treat there, what is the depth of the scarring, what is the pathology depth, because that's very important to know whether there's already involvement of the anterior, mid, or posterior stroma, whether the DM endothelium is scarred, and of course where is the involvement, whether it's a centered, decentered, apical scarring, and as we can see, whether there's scarring of the endothelium. So here I find the anterior segmentosity, in addition to, of course, our clinical examination, quite useful, especially to try and measure the depth. In a lot of advanced ectasias, keratoconus, you can still have a lot of scarring. That does not mean that we can't do a DALK. So we have done DALK even for a post-hydrops case once it's scarred, but you really need to measure it and look at how that opacity is and plan your surgery and your technique for surgery. So there are various techniques, and the most common and popular being the big bubble, but over time we've realized that a lot of manual dissection is our fallback method or the first method of choice for this surgery, and we'll be going over a few. The beauty, I think, of DALK is that very often we need not have any high-end diagnostics or instrumentation. We don't need very costly instruments. We can manage the surgery with a lot of instruments that are available to us in our OT already. And I think if we are starting out DALK, one of the most useful instrument or must have in my book is a blunt tip scissors, because it really helps with your dissection, be it your big bubble or your manual surgery. So when we are planning the big bubble, very important to remember if you're using a needle or a cannula. So it's important to remember, especially when you're using the needle, what is the location of your needle, what is the direction of your needle, and the depth. So when we mean location, you try not to be too peripheral. You need to be directed towards the center, and of course the depth, because if you're too superficial, you're going to get a lot of emphysema and not the big bubble, which is usually formed between the stroma and DM endocomplex or the predecimetic layer, depending on the type of bubble. So the next step is releasing the bubble. So once we form that big bubble, we need to release it, and here one very useful tip is to put just a dot of viscoelastic on your bubble there to slow down the egress of air. Otherwise, it will come out in a big gush, and when you're releasing your bubble with a sharp instrument, be it your side port knife or any other instrument, you might actually nick the DM. Also, another useful thing is to do a very shallow paracentesis to reduce the pressure in the eye, so that the bubble does not egress with a sudden gush of air out. So I'll just show you as we're doing. This is the shallow paracentesis. I put in a small bubble into the AC, and this double bubble really helps us, because when the big bubble is in the AC, that other bubble would be peripheral, and once you have released the big bubble, it moves centrally. And this really helps if you've taken a few attempts to make your big bubble and there's a lot of emphysema there, not very visible, not very clear if you release the bubble, then that movement of the bubble in the AC really helps. Followed by the quadrant dissection of the stroma, which is quite straightforward. You need your blunt tip scissors here, absolutely essential, and then a careful quadrant dissection would help you to unmask that mirror-like glaze of the DM endocomplex. Now, what are our alternatives? And this will be taken in detail by our next speakers, but just because we have a deep scar does not mean that you can't go ahead with the DALK. This is still possible even in a post-hydrops scar. So a lot of people are very worried about the bubble and challenges with the bubble. So just a few things that you need to keep in mind. Of course, the instruments, as I said, you don't need too many major instruments, but a few important ones like the blunt tip scissors. And of course, how much pressure is required. So a lot of people use either the 5cc or 2cc syringe. It would depend on what your hand is good with. The idea is that you should have a controlled ingress of the air and not a sudden burst of air there, because if in case you're in the wrong plane and you suddenly push in air, there'll be a lot of emphysema and that will blur your next step. So I personally use a 2cc. The only downside to that is in case you've not filled it fully, then halfway through you may run out of air and your bubble will not be complete. But as long as you have the full syringe, it's going to be a very controlled ingress of the air. So how do I know that the bubble will form? And this is quite an easy thing that you look. If you look at this video, first the air comes out, but once it starts forming in the center, you see these little spoke kind of structures that are there. Look very closely where the needle is, and you see these slight spokes coming out, and that usually denotes that you will get the bubble even though there was a slight emphysema. To show the contrast, I'll play the other video where you can see that when the needle is inserted, the bubbles form almost like a small, just like a blob, and they don't really spread out. So if that is there, please stop. You're not going to get the bubble from there, and you're going to make the entire cornea emphysematous and not be able to take the, go to the next step. So this is what I was saying. Understand the air dynamics. If your bubble or air is coming backwards, you need to stop. Don't keep injecting, because then it's not going to help. And in this case, you'll see how it suddenly goes into a full, it spreads, and that's much more difficult to get the bubble after that. Next question is, how many times can you try the bubble? So there's really no rule to that. So you can try as many times as long as you have a good visibility of it. And it becomes more difficult once you've tried a few times, because the air tries to pass into the point of least resistance or path of least resistance. So you can see there's a lot of emphysema here, but in the next step, you can still achieve that bubble. And all of this is being done with just a 30 gauge needle. Of course, a cannula makes it much more easy, less chance of perforation and complications. When the air enters the anterior chamber, okay, you have to make sure that it's not a perforation. So if the air comes in from the periphery, you know that it's just passed through all around and come through the trap. But if it's come directly into the center, you would suspect that you've had a microperforation and should probably take it a little more conservatively. The last thing I'd like to show is, suppose you made the nick, but your nick was not deep enough. It was very superficial and you can't really find the plane. Then there are ways to try and find that dissection. But if not, then you would have to resort maybe to a manual way. So the idea is to get that instrument into a smaller, that space, because otherwise that entire creation of the bubble that you've done would be to naught. Here finally we found the plane, and then we'd be able to uncover the DM. So just in case we've done a manual DALK, it does not really mean anything. Very good results even with manual DALK over time. It's just that the big bubble DALK has extremely good early results, and I'm sure Dr. Rishi would be covering that. It's not that DALK does not have complications. There are certain complications that we have to keep in mind to try and prevent, and especially many of them have a lot of allergy, especially the ectasias. So you can have surface issues which you need to deal with. So I'll hand over the mic to our next speaker, Dr. Rishi, who will be telling us his excellent technique of the groove and peel and how to go ahead with manual dissection. Thank you.